Thank you very much. These are my disclosures. It's really great to be here and to see those great cases that were done today and be part of this meeting. I had the pleasure to debate with one of the best friends that I have in the field. And maybe I don't have many, but Roxana is still one of them. And she actually is so beautiful, as you can see here. She's so smart. She always wins. I'm not sure she always right, but she always wins. But in this case, she is right because she's PI of a short DAPT and she's PI of a long DAPT. So I don't think that there is any way you toss it. So I'll try to bring you the case why short DAPT drug-eluting stent getting better. The drug-eluting stents indeed are getting better. And you can see the progress over time. We're getting to better and better stent, thinner struts, no events. It's almost hard to make any trial anymore because the event rate is so low. So the question, do we really need to have a long DAPT for those stents that actually were initially designed for the first generation DES? Now, again, just to prove you, when Robert Barn was compare and contrast bare metal stents, early DES and new DES, he showed that almost on any parameter, the second generation DES are doing better compared to the old one. And remember, the regime of DAPT for 12 months was directed towards Taxus and Cypher, which are no longer available. If you look on short DAPT in stable CAD patients, they fare better. In a large meta-analysis of 11,473 patients, so clearly they are better. But why they are better? Because primarily any bleeding and major bleeding is much less. And bleeding is really critical. We are always debating between ischemia and bleeding, where bleeding is causing harm and where is the better way to go with that. And again, this question is coming along. And we do have analysis that actually did show us that if we have MI versus minor bleeding, the MI counts more. But if we have MI versus major bleeding, which is BARC 3, then you can see that the bleeding counts more and they are higher risk for mortality. So that is, I think, a very compelling argument to show the DAPT as much as we can say we can have it, and on the stent level we can have it. So this was created by the DAPT group. They created the DAPT score that everybody is familiar with that. And actually the score is outlined here, and you can see here that if you are -2, it's bringing to harm. If the DAPT score is less than 2, and then if the DAPT score is greater than 2, it's bringing you to the benefit. But that's actually is a good guidelines to tailor your therapy if you have a DAPT score less than 2, and this is on 500,731 patients. If you continued thiropyridine, you don't see much of the benefit. But if you have the DAPT score greater than 2, then if you look at this, then you're going to have much differences between 2.7 to 5.7. So again, there are some guidelines if you want to use the DAPT score. Now, you can look at this algorithm, which I think is very practical. You have to give everyone for a short period of time, which probably everybody would agree at least 30 days. And then you have a patient assessment. And then you have to look whether the patient is at high risk for bleed or high risk for ischemic event. And based on that, you can decide if it's a high risk for bleed, you stop the DAPT. If it's a high risk for ischemic events and low risk for DAPT, then you continue the DAPT. So I think it's very easy to follow that track. Now, if you look at DAPT discontinuation for Zions, for example, so you see that if it's less than 30 days, the stent thrombosis is still going to be higher. So no one is arguing less than 30 days. But if you look on 30 to 90 days, it was 2.78. 90 to 180 days, it's about the same. So you can actually settle on 3 months very easily because there is not much difference between 90 to 750 days. So that's a thing we learned. The other thing that we learned, and that's actually from Roxana, that the impact of bleeding on mortality is not fading and its significant remains within time. So we have to take this into consideration. And then Palmerini also looked on bleeding that related to death. So the only motivation that we have to stop the DAPT is to prevent those bleeding, because those bleeding are associated with death. And that's, I think, why we should thrive. In some patients, not even to go to 3 months, but also to go to 1 month. Now, there are many HBR criteria. This one was used in the leaders-free study, and many of those with some iteration are being used now in other studies. But I think if you look how many patients do fit, that it's pretty high number. So how is the data for the high-risk bleeding? If you look on the azoterolimus eluting stents versus bare metal stent from the ZEUS study, we see that actually those groups who had a short duration did pretty good compared to bare metal stent. So there was no really penalty when the DAPT was used for 1 month in both arms, and that was with Endeavor. Now, if you look on the senior trial, you see the similar thing, 1,200 patients. This one was using Synergy, everolimus eluting stent. And again, does show that there is really no penalty when you show the DAPT in a shorter duration time in these elderly patients. And again, when you compare to bare metal stents, you always have the effect of anti-proliferation. The leaders-free showed us the same thing. These were the inclusion criteria. And you ask yourself, how many of those patients really fits? In the burn registry, it's about 40% of the patients fit some HBR criteria. So it's a pretty large number of patients. This is the data from the leaders-free trial that did show that even a polymer-free stent, 120 micron, did better than bare metal stent in all aspects. So the guidelines in Europe says that DES should be used for every patient. There is no room anymore to use BMS whatsoever. And then here is an algorithm of the DAPT duration after PCI that actually does support use of the 3 months as a class 2AB for patients who are at high risk for bleed. I think that what we have to remember is that we need randomized clinical trials, and these are coming. And this is the list that basically summarizes almost every stent now running a study comparing the short duration. So we have 2 weeks. This was not exactly drug-eluting stent. There was a passivated coating. Then you have the Evolve Short DAPT, which completed enrollment in 3 months using the Synergy. You have the Master DAPT with Ultramaster that's outside of the US. You have Resolute Onyx, which is going to be 1 month. You have Poem, which is Synergy 1 month. Stop DAPT 2, Science 1 month. And then you have the Science 90, which Roxana is the PI with 3 months in the US, and Science 28, 28 days with Science outside of the US. So I think we'll learn a lot from those studies. I will conclude that new generation DES represent the treatment of choice in all patients undergoing PCI. Bleeding risk varies, and HBR patients should be assigned to short DAPT. Substantial number of patients should not take a full 6 to 12 months. We have to admit that, and we have to give them shorter duration. I think it's good to start with 3 months. The polymer-free DES showed that you can do it with 1 month. New generation DES are ideal platform to test the safety and efficacy of short DAPT duration after PCI and HBR patients. And so far, in the absence of head-to-head comparison, we cannot call it a class effect, although I think at the end of the day, when we'll have the data from all the studies that I showed you, we will say that time to change the guidelines to 3 months. Thank you very much, and I hope to see everyone at CRT.